Hey, Onco PTs, and welcome to this episode of the Onco PT podcast. I don't know about you, but September cannot get here fast enough. I am sick and tired of the extreme heat that is going on here in Texas and much of the rest of the world. September is also selfishly my birthday month, and I'm really excited to start partying it up once September 1st rolls around. But beyond the personal reasons, the personal motivations for why September cannot get here fast enough, today is going to be a fun episode because we are going to highlight one of the cancers, actually, one of the multiple cancers that claim September as their awareness month. There were a lot, I'm not going to lie. When I was looking ahead at this episode, I thought, you know what? We haven't done one of those like return to basics episodes in a hot minute. So why don't I look at the September Cancer Awareness months, diagnoses, and I'll pick one and I'll cover it. When I tell you I was not prepared for how many cancers are listed on that list, I do not exaggerate. So I'm looking through the list and I thought, well, there's just a lot here. I kind of don't know where to go from here. But something stopped me in my tracks. So specifically, September, one of the diagnoses is thyroid cancer. September is Thyroid Cancer Awareness Month. And I thought to myself, I don't think I've covered thyroid cancer once on the podcast in the almost 5 years that I've been doing this. And it actually got me thinking, there's 3 people in my lifetime that I've encountered with a thyroid cancer diagnosis. And 2 of them, interestingly, were people that I went to school with. So both before I graduated high school and then when I went to college. So one person each. And then I did have one patient in my time so far as an oncology physical therapist who also had thyroid cancer. And it was so interesting to me reflecting on those 3 cases and then doing a little bit of a dive into the research to see, what is the info on thyroid cancer? What are the numbers? What are the statistics? And just thinking about who the people were that I've encountered with thyroid cancer, how they were affected, and then kind of what the research says about this and the differences that I see between my own anecdotal experience and then also the literature. So again, zooming out, these questions were kind of swirling in my head. And then I thought to myself, I haven't done it yet on the podcast. I should probably start talking about it. So we are going to talk about the basics of thyroid cancer today, but not just what it is, how it's treated, but ultimately what this could translate into in your clinical practice, right? What does all this information mean for you when you do encounter the patient who's been diagnosed with thyroid cancer? Not saying it's common. I'm not saying it's going to make up a majority of your patient load by any chance, but these patients are out there. And I think we kind of push them aside or brush them under the rug because it's not like a sexy diagnosis. It's not the big pink that we see for breast cancer, but it still affects patients. And there's information suggesting that thyroid cancer may actually be on the rise, and that is worth paying attention to. Now, the good news. Thyroid cancer is relatively uncommon, has great long-term survival rates. Amazing. We love that. It's a little bit of some fresh air when it comes to this oncology world. But we're going to follow that up with some not so good news. Thyroid cancer is still cancer. Period. Full stop. And thyroid cancer, because it's cancer, and these patients frequently undergo cancer treatments, these patients can experience some very significant functional mobility limitations and quality of life issues that absolutely affect them and their ability to do what they want to do and what they need to do. And that should concern you and me, which is exactly why we're diving into thyroid cancer today. Hello. If I didn't introduce myself already, my name is Elise. I'm the host of the OncoPT podcast. I'm so excited that you're here. No matter if you've been practicing for just a couple days, if you're one of our newbies who just graduated, who just passed your NPTE, welcome. We're so excited you're here. to all the way to our veterans here, right? If you've been around oncology patients for a few years now, welcome. We're so excited you're here. This episode is going to help refresh you and review some of the really critical information you need when it comes to treating your patients after a thyroid cancer diagnosis. So zooming out, if we look at thyroid cancer by the numbers, thyroid cancer is relatively uncommon. It makes up about 2 to 4% of all cancer diagnoses in the United States. Again, rare, good. I'm excited for that. But it still happens, and we still need to be aware about it. Even better news is that thyroid cancer has about a 98 to 99% 5-year survival rate, which is so exciting. I feel like I never see that in cancer, period. And so it's so lovely to see that thankfully thyroid cancer is caught and treated relatively easy in the grand scheme of things for the vast majority of our patients, which is so exciting. Again, real breath of fresh air here. And the deaths from thyroid cancer truly only account for about 0.3% of all cancer deaths in the United States. This does differ, it seems, in other countries. There's some really good research coming out of South Korea that is very focused on thyroid cancer that I don't feel like I've necessarily encountered here in the US. And I do think it's because there is a greater proportion of patients who are diagnosed with thyroid cancer in South Korea and maybe other countries compared to the US. So you'll hear me talk a little bit more about this research coming out of South Korea because it was very useful when researching this podcast. Now, even with the general statistics of thyroid cancer is not that common, it's got good survival rates long term, it does seem to be on the rise worldwide for a few different reasons. And what was even more surprising for me as I was researching this podcast episode is that thyroid cancer is statistically the 5th most common cancer among American women. I was not prepared for that. I was quite shocked by that. And again, thyroid cancer, relatively uncommon, but it's not non-existent, right? It still affects our patients and it still warrants us to listen and pay attention to, right? So when we look at thyroid cancer as a whole, looking at the thyroid, there's 2 major cell types that will contribute to thyroid cancer. 90 to 95% of thyroid cancers are going to arise from the thyroid follicular cells. So thyroid follicular cells, when they go rogue, when they give rise to cancer, they're going to give rise to a type of thyroid cancer called differentiated thyroid cancer, DTC. Again, the vast majority of thyroid cancer diagnoses, 90 to 95%. The other big cells within the thyroid are called parafollicular or C cells, and these contribute to a type of thyroid cancer called medullary thyroid carcinoma, MTC. And this is about 1 to 2% of all thyroid cancers. There is a tiny fraction of thyroid cancers that are called anaplastic thyroid carcinomas. This is like 1% of all thyroid cancers. So when you encounter a patient with thyroid cancer, the greatest likelihood is going to be that it is some kind of differentiated thyroid cancer from these thyroid follicular cells. Now, before you start spiraling here, there is no quiz after this podcast episode. This is a purely FYI section that just helps you to get a little background information on what we're talking about here. The rest of this is going to be much more pertinent to how do you practice as a cancer rehab professional working with these patients. So you can get those stats out of your head now if you want. Now let's get into the risk factors. Thyroid cancer, at this time, as of the recording of this podcast episode in 2023, we don't have great information on why thyroid cancer exactly happens. There's not a very clear link between this and then the development of thyroid cancer, right? If we think about, I'm going to throw lung cancer under the bus here. Lung cancer, one of the biggest, most well-documented documented, well-researched risk factors associated with lung cancer is smoking, right? Very, very clear. Is that the only reason patients develop lung cancer? No. And we've talked about that previously. But it's a big part. It's a big factor, right? So if we look at lung cancer compared to thyroid cancer, lung cancer, pretty clear risk factors, contributors to the development of lung cancer. We don't necessarily see that same relationship when it comes to different risk factors and thyroid cancer. There are some risk factors for thyroid cancer. For example, female sex. Women are more likely to develop thyroid cancer than men, at least here in the United States. Why is this? I don't know. I don't have a darn clue. But it seems to be a risk factor. Other risk factors include familial history of thyroid cancer, as well as radiation therapy to the head and neck region. Interesting. Kind of makes you think about some of our other patient populations who may be at risk, right, of developing thyroid cancer, a secondary, cancer diagnosis later on down the road. In addition, there are some genetic mutations and syndromes that may predispose a person to developing thyroid cancer. We're not going to get into those specifics for this episode. But the vast majority of thyroid cancer diagnoses seem to be a combination of multiple factors and straight up just bad luck, right? We know that cancer is a very complex, multi-layered formula when it comes to why patients get cancer and then why some patients don't get cancer. Thyroid cancer seems to be one of those, like, it's just plain bad luck, which sucks. Most thyroid cancers are detected incidentally with neck imaging, which I think is quite interesting. There are some potential changes the body can, manifest with when a thyroid cancer is developing. For example, some patients may present with neck swelling, palpable lymph nodes, maybe even some constitutional changes, but most of them seem to be diagnosed after the patient happens to go in for something else. They do some neck imaging and see something that's like, ooh, that's not very good. Now, once a patient is suspected to have thyroid cancer, they will usually undergo some kind of thyroid function panel, and then maybe a fine needle aspiration, maybe even molecular testing. But as the rehab professional, you and I are not responsible for doing this, right? This is kind of everything that happens before a patient usually makes their way to us, before we go and see that patient. But again, I think this is helpful background information to know exactly kind of where are we at? What is, what are we getting into with this patient population? Because now what we're going to talk about is the typical treatment for thyroid cancer. Thyroid cancer, most commonly, first line treatment is going to be surgical removal of that cancer. So ideally, the surgical team is going in to try to remove as much of that thyroid cancer as possible. This may be a lobectomy, where we're removing just part of the thyroid gland. But it could also be a complete full thyroidectomy, right? Let's take it out. Let's get rid of it. Let's not even deal with it anymore. So it kind of depends on, what kind of cancer I'm sure your patient has, how advanced it is, how much it's spread. And I'm sure you've already thought of this, but some patients may actually undergo a lymphadenectomy to remove any potential or sus or already cancerous lymph nodes in that area. And again, this is already hopefully setting off some warning bells in your mind about potential implications for rehab for this particular patient population. So once we're done with surgery, depending on, if it was early enough, it was localized enough, surgery may be the stop of treatment for patients, but maybe not. So for some patients, they will go on to do some kind of radiation therapy. Most commonly first stop when it comes to radiation therapy for thyroid cancer is going to be this radioiodine ablation therapy. So they are using radioactive iodine adjuvantly after surgery to treat any residual disease, or any kind of metastatic disease, present in the area. The one patient who I have seen professionally do for thyroid cancer related impairments had this radioactive iodine therapy after they did her thyroidectomy. She then went on to also undergo thyroid hormone suppression therapy. Now, the reason that thyroid hormone suppression therapy is done, again, usually after surgery, we are now trying to keep the hormone TSH low, because for cancers that we kind of talk about like this in, breast cancer, gynecological cancers, other hormone driven cancers, we know that cancers can basically use that hormone as fuel. This is one of those cases. For cancers, for thyroid cancers that like quote feed off of that hormone, this thyroid hormone suppression therapy can help decrease those hormone levels so as to try and reduce the risk of that thyroid cancer coming back. Again, not every patient will undergo this, but it seems like a lot of patients will start thyroid hormone suppression therapy after surgery. Beyond surgery, again, these are kind of first line therapies for most patients with thyroid cancer. Some patients may have more advanced cases or more aggressive thyroid cancers and need additional treatment. We're seeing the rise of targeted therapies, immunotherapies, etc., being used in the management of thyroid cancers, which is pretty darn exciting, personally, for me. So, targeted therapies use more and more. Some such agents that we see include multi-kinase inhibitors, RET inhibitors, TKR inhibitors, BRAF inhibitors, and MEK inhibitors. Now, if I just kind of barfed alphabet soup onto you, don't worry. I don't fully know what each of these acronyms mean, except that they target very, very specific components of factors that potentially affect the development and return of thyroid cancer. That's what you need to know. I did a super brief dive into chemo care for each of these for more of like my own edification. Very helpful. Would recommend. We're not going to dive into that level of detail on this particular podcast episode. It's just too much, y'all, and we don't have enough time for that. But just know that there are several classes of targeted therapies, immunotherapies, that are being utilized for thyroid cancer, and I predict that is only going to increase. So if you can even just acquaint yourself, familiarize yourself with the different like classes of targeted therapies that are going to be used, it can just make it a little easier when you're doing a chart review for your particular patient. Now, some cases where the cancer is maybe more spread, maybe even like global systemic at this point, some patients with thyroid cancer will undergo chemotherapy. Some common agents include dacarbazine, vincristine, cyclophosphamide, doxorubicin, and others. But I picked out these agents because, again, they were listed at the top of the chemo care kind of debrief. But also, these are the agents that I tend to see most commonly in my other patient populations. So again, thinking about cyclophosphamide, doxorubicin, those are huge in my breast cancer patient population, right? I feel like that's first line for so many of my patients. And because of that, I think we're quite familiar with some of those side effects, which can affect functional mobility and quality of life for our patients, which we will talk about in just a second. Last little bit of treatment here, and then we'll actually dive into those impairments. Some patients may require external beam radiation. This is maybe for cancers that are not appropriate for surgical removal. Maybe this is for cancers that don't take up that radioactive iodine, like we talked about previously, and need some other form of radiation, or maybe even cancers that have spread beyond the thyroid and we need more treatment here. Typically, this is not used for those more common DTC thyroid cancers. This is for medullary thyroid cancer or carcinoma, as well as the anaplastic thyroid cancer. Not very common. I think all of the people that I have encountered with thyroid cancer up to this point in my career, which is not that many, let me be clear. It's only like 3 people at this point. I don't think any of them actually had external beam radiation. I think all of them had the radioactive iodine therapy. Could be wrong, but I am quite sure of that. Because again, those medullary thyroid carcinomas and anaplastic thyroid cancers, not very common. Like maybe somewhere along the lines of 2 to 5% of all thyroid cancers. Not super common. Definitely going to see much, much more in this patient population, statistically speaking. Surgical removal, radiation, or radioactive iodine ablation therapy, and then that thyroid hormone suppression therapy with maybe a couple other things sprinkled in there. Now, what this all means for us, right? We've kind of gone through what is thyroid cancer? How does it present in patients? How is it treated? But we really haven't answered the question of what the heck does this mean for us as the rehab professional? Here's where we're going to get in that. A lot of the information that has been covered so far in the rehab world, so I'm speaking specifically to PT, OT, etc., when it comes to actually rehab work with these patients, really comes in the context of not thyroid cancer by itself, but kind of what other umbrella can we lump this patient population under? Specifically, I do see a little bit of information like crossover between the head and neck cancer patient population and then thyroid. Let me be clear. Head and neck cancer and thyroid cancer are not the same thing. They are classified very differently. But I do think for the purposes of discussing potential rehab implications, the crossover, and lumping them together does make sense in some cases, particularly when we think about some of the impairments these patients can face. So geographically, anatomically, when we talk about a thyroidectomy, there is probably going to be some kind of surgical incision on the front of the throat. Not the same as our patients who undergo a neck dissection, but similar and quite close by to where we could expect like the more typical neck dissection scars to end up, right? At least with most of my patients so far. So thinking about that, there is crossover, there is overlap that is very, very appropriate for thinking about what these patients could experience. So first and foremost, potentials for local pain and dysfunction secondary to surgery. Again, it kind of depends, but one of the articles that I referenced talked about potential spinal accessory nerve depending on where the surgery was and how much of the tissue was implicated, right? This is not saying all patients who undergo a thyroidectomy are going to experience this. It's a possibility. And there's other structures in there, right? Thinking about, it may not just be that nerve, but depending on, again, how much tissue was involved, how much tissue was disrupted, this is a very real possibility for patients, is that they could experience not just obviously very local anterior neck impairments, but also maybe a little more regionally, right? Maybe not just the anterior neck, but the lateral and then even posterior neck, maybe even the shoulder area, maybe even there's some periscapular dysfunction. There's a lot of things in here that could be potential issues here. And so this is where I want you to put on your kind of head and neck cancer cap and think about how could my patients with thyroid cancer and after thyroid cancer treatment mimic or mirror or resemble some of the patients that I see after head and neck cancer treatment. Another big thing that I thought about here, especially when it came to some patients may undergo a lymphadenectomy, lymphedema. For heaven's sakes, if we think about like that giant scar on the front of their neck, that is a potential stopper or a barrier for the flow of lymphatic fluid. Maybe it's not as big or significant as our patients with head and neck cancer, but it could be a thing. And it could be something to really think about. Again, not just even external lymphedema, maybe internal lymphedema could be a factor here. Again, like I said, I have only encountered 3 people in my entire career so far who have had thyroid cancer. I don't approach this topic as someone who is the expert who has ample experience. These are things that as I was reading and researching about, I was thinking to myself, here's kind of where my brain goes as far as impairments here. So lymphedema could definitely be an issue for these patients. Another thing to think about is fatigue. This is probably for a few different reasons. We know that patients frequently experience fatigue as a result of the cancer itself, maybe even the aftermath of surgery, even the psychological aspects of being diagnosed with cancer could be a contributor here. I know for a fact radiation contributes to fatigue. As far as the effects of that radioactive iodine, I don't know as much about the fatigue there, but it's a possibility, right? We see it with other radiation. Could it be with that as well? I don't know. Maybe even chemotherapy, maybe the targeted therapies. All of these things could contribute to this cancer-related fatigue that we know is so prevalent in some of our other patient populations. Additionally, bone loss is another interesting thing that I originally did not think about in this patient population. Few different things here, but I really want to focus in on the thyroid hormone suppression therapy. This seems to be most prominent in our postmenopausal female patients. We don't necessarily see the same trend in men or in premenopausal women, but it did note, one of those sources that I used did note that patients who are postmenopausal women may be at an increased risk of bone integrity issues and bone loss, predisposing them to osteopenia, osteoporosis, and even bone fractures in some cases. Now, you and I know this is definitely a big thing that we see in oncology, period. And I think it's worth mentioning here because this is not automatically where my brain would go with this particular patient population, which again is why we need to be thinking about these things, because this is totally something that is worth mentioning. Now, kind of related to the local pain and dysfunction and the lymphedema, scar tissue is definitely something that I wish I would have thought about more when I was first thinking about and working with this patient population and what I will implement moving forward. With the scar, again, typically what I've seen in the literal 3 patients I've ever encountered with thyroid cancer, they had a scar right across the front of their neck. And again, that makes sense. That's usually where the thyroid is most accessible for surgery. And one thing that I think was very underplayed for United States literature, but was discussed more in the research that I read coming out of South Korea, is the psychological implications of that scar that is so forward facing and prominent, especially all of the patients that I've seen previously were under 50. And again, I feel like you can make all kinds of assumptions about this, but even from an aesthetic and a self-confidence and body image perspective, this is something that is very prominent for patients. I know the 2 young people that I encountered with this, it was extremely obvious. And it draws attention. And I can absolutely see where this could make someone feel uncomfortable and, like self-conscious and be hyper vigilant of how they're being perceived and thought of in all of this. And again, it was so interesting because in the South Korean literature, they talked about how this is maybe more important in South Korea than it is in the United States. But that doesn't mean it's not important for our patients here in the United States, right? This is something that we may have to think about a little more. Everybody is built differently. Everybody has different perspectives. Be hyper aware of that, because that may be something that bothers your patient more than necessarily what the literature suggests. I think that's a good lesson in general, but that's something that I was thinking of as far as like, maybe we need to do a little more investigating into this for our American patients, or patients of other cultures. Anyways, I think that could open up a whole can of worms. I'm not prepared to here on this podcast, but I do think it's worth mentioning. I do think it is worth considering that this could be a really big issue for patients that we are not even talking about as healthcare professionals. And I think that leads rather nicely into the last little component here, which is decreased quality of life. And what I found interesting is that this is not just related to the aesthetics, the external appearance of scars, but something else entirely, which, as someone who, again, I've never had cancer, I've worked with these patients, but that doesn't mean that I have the true insight into what these patients are experiencing. And this was a real wake-up call for me personally. And I hope you'll take something similar away from this discussion. So, of course, cancer diagnosis, right? We know the effects that it has on a person's quality of life. We also know that cancer treatment has a ton of side effects, which can contribute negatively to a person's quality of life, right? We've talked a little bit about the body image and self-esteem, self-confidence issues that can accompany such a prominent anterior-facing scar in an area that is most commonly uncovered with clothing, right? I don't have a lot of shirts that are turtlenecks per se. But one thing that was so interesting in this particular research article I referenced out of South Korea is the decreased quality of life from this patient population that they talked about as having their experience diminished or belittled accidentally, but also intentionally by those around them. Let me explain. In this article, there's a beautiful quote that stopped me in my tracks, which says, thyroid cancer survivors highlighted having their cancer referred to as the, quote, good kind, end quote, trivialized their diagnosis and decreased health-related quality of life as they felt unsupported by physicians and family. That one caught me off guard. And I think it's such a powerful continuation of a conversation that I was having with a follower on social media the other day. So this was in reference to episode 261 that came out a couple weeks ago, talking about just how we can be more intentional in curating a compassionate, supportive, caring therapy environment for our patients and believing our patients when they tell us something the first time, and ultimately not blaming them for something that's not their fault. Like, cancer is never somebody's fault, period. End of discussion. There is no good cancer. Cancer is all bad. It all sucks. It's all terrible. And it affects patients so differently in ways that are all valid. And I think we need to do a much more intentional job of never referring to a cancer diagnosis as a good kind. Because there is no good cancer. And when we tell patients that, oh, you're so lucky, like you only have this type of cancer, not that type of cancer, or, oh, like at least you've got a good cancer. What are we telling patients, whether intentionally or unintentionally? We're telling them that you should just be grateful. You should just be happy that you don't have the same cancer diagnosis that Susie over there has. You should just be happy to be alive. Completely the wrong approach to take in all of this. That has no place in cancer rehab. And it's so wild to me that this very unintentionally, when I was first looking into thyroid cancer for this episode, it was wild to me how many themes from that episode came up in the research for this episode. But I think it really underscores just how important it is that we are not unintentionally or intentionally contributing to decreased quality of life for our patients in how we address them and their diagnosis and their concerns. And that has been a really interesting insight that I've taken away from this research, this very brief surface level research that I've done for thyroid cancer, is it's still cancer. It still affects patients. So we need to care about it, and we need to care more intentionally about it, and we need to be paying attention to these things so that we can ultimately be a better physical therapist, occupational therapist, etc. for our patients with thyroid cancer. I've only encountered 3 so far. I've only treated 1 patient professionally so far, but I know there's going to be more. And in fact, there could be more than what I'm even paying attention to, because I really haven't been paying attention to it at all so far. And that's on me. And it's on you to learn this information and to show up more intentionally for your patient so that you can be the best rehab professional that that patient needs in that moment to address their concerns and to believe their concerns when they tell you the first time. There are some amazing resources out there for thyroid cancer. In fact, coming up, which I thought was so timely, on September 25th, 2023, there is an NCCN tumor board called Management of Differentiated and Medullary Thyroid Carcinomas happening. It is online and it is free, which I'm super excited about. This is not paid, right? They did not ask me to promote this, but I thought, what a better way to kind of commemorate and call attention to Thyroid Cancer Awareness Month, which is September, and to better educate ourselves on what the heck is going on with this patient population. How can we better show up and serve them based on the needs that they have, that the impairments they're experiencing? There is also a really, really great website out there that is, I think, the Thyroid Cancer Survivors Association. It's called ThyCA, and I will link to it in the show notes. They had this amazing 50-page free downloadable mini book that talks all about what is thyroid cancer, what to expect when you're diagnosed with thyroid cancer. And I think that is a really great resource to have on hand that I can save and that I can send to patients like via email after our visit with each other. So many different resources out there. I've also included all of the references that I used to gather all of this information for this episode. And there's some really, really good stuff out there. And I would really encourage you to check those out. Because like I mentioned, I haven't seen a lot of these patients yet, but I do anticipate I'm going to see more, and I need to be aware and ready for those patients. And I'm going to say, you do too, friend. No matter how long you've been practicing, no matter where you practice, you could encounter these patients, and we need to be ready for them. So until next time, this is Elise with the OncoPT podcast. And remember, you are exactly the physical therapist that your patients with cancer need. So let's get to work.